This lesson will cover the highlights of skin in MSK-related soft tissue point-of-care ultrasound. The soft tissue structures we won't go over in this lesson are endocrine structures, vasculature, and ocular ultrasound, so expect these in another lesson. We will go over normal skin and subcutaneous findings, as well as some of the most common conditions encountered by generalists in both the inpatient and outpatient settings. After reviewing the normal appearance of skin and the subcutaneous layers, we'll cover the typical appearance of foreign bodies using ultrasound, and hopefully you'll see some of the advantages of using ultrasound over a plain film radiograph for identifying and removing those foreign bodies. We'll go over some of the common infectious etiologies that affect the skin and can change their sonographic appearance, and we'll go over the utility of ultrasound for lumps and bumps clinic, investigating and characterizing a variety of palpable findings such as cysts. Lastly, we'll touch briefly on some of the findings that should raise suspicions for malignancy and prompt you to investigate further. Let's start off with a look at normal skin and soft cutaneous tissues appearance using point-of-care ultrasound. The sonographic appearance of the superficial bodily structures depends on recognizing layers. Recall from our ultrasound physics lesson that echoes, aka the white lines we see on 2D ultrasound, are generated by impedance of the sound wave propagation through structures that have different densities and echo properties. The most superficial layer is the skin, and the POCUS machines generally do not have a high enough resolution to differentiate the dermis from the epidermis, so these often appear as one structure or set of lines immediately deep to the probe. Sometimes you'll need to use a water bath or a gel offset to be able to distinguish the skin from the transducer itself, especially in areas where the skin is thin or the curvature of the body makes contact with the probe difficult. Deep to the skin is the subcutaneous layer, which often has a variable amount of adipose tissue and small perforating vessels and sensory nerves. Typically, there will be a layer of connective tissue, or a fascial plane, that separates the subcutaneous tissue from the musculature and deeper structures. Fascia is typically pretty linear, brightly echogenic, and is often the target point for nerve blocks or identifying vessels for venipuncture or vascular access. And then finally, the muscle tissue will generally appear hypoechoic with linearity or fasciculated myofibers that help determine the direction of the muscle's contractility. Now let's take a look at an actual ultrasound image, and it's pretty easy to make out the top dermal layer and the muscle layer, which is the deepest layer here, due to its relatively hypoechoic appearance. And then as we work back up from the muscle, we can see the fascial plane with the set of linear structures that are brightly echogenic, and then anything above that is likely subcutaneous tissue. There may be an extra little fascial plane in here, or it may just be that there's a little collection of fat kind of in this zone here, but generally we can see the muscle, the fascial plane, subQ, and then this line up here is skin. Lots of variables affect the appearance of the soft tissue on ultrasound in ways that can make things appear brighter or darker. Some of the most common reasons that structures appear more echogenic include machine settings, which is usually having the gain too high, or using a preset that's ill-suited for these areas. Significant adipose tissue can also result in increased echogenicity because those little globules of fat create a bunch of echoes at every border between lipid and aqueous interfaces. Most commonly, hypoechoic appearance of these structures can be traced back to machine settings once again. Or it could be due to poor propagation of the sound waves into the body due to a poor transducer gel-skin interface, or from tissue edema caused by volume overload or leaky vasculature or trauma or other processes, and we may jump into some of those here in this lesson. So now that we can identify normal skin and subQ, let's put into practice by studying how foreign bodies appear when they invade the normal matrix of these layers. Foreign bodies in the skin and soft tissue should be considered in all patients who present with wounds, especially when the history of injury suggests that there could be a retained body. Foreign bodies are usually quite superficial, and so they can be pretty easily missed if excessive pressure is applied with the probe, bringing the foreign body too close to the transducer to be recognized as a separate structure. So for this reason, I often use a standoff pad, such as a gel mound, or a bag of saline, or a glove filled with water, or I immerse the patient's extremity in a water bath when attempting to visualize these bodies. In the primary care and emergency room settings, radiographs or CT are often used to identify the nature and location of foreign bodies, but these modalities have limitations on what they can visualize, and X-ray in particular can leave us guessing where exactly the object is in 3D space, unless we take multiple radiographs and use stereotactic pins or markers to help guide our anatomy. For this reason, ultrasound has emerged as a better modality for both visualizing structures and guiding their removal with dynamic imaging. One study that I read said that there's a sensitivity of greater than 80% for experienced scanners to identify and remove the foreign body, which is pretty good for a point-of-care application. The appearance of foreign bodies using ultrasound varies somewhat based on their material, their location in the body, and their orientation to the probe, but they will generally appear as hyperechoic or bright with posterior acoustic shadowing. If the body is metal, hollow, highly reflective, or oriented exactly perpendicular to the direction of the ultrasound wave propagation, it has a higher likelihood of generating a reverberation artifact or comet tails, twinkling artifact, etc. However, these artifacts aren't always seen and they're not necessary for diagnosing a retained foreign body. Here we have two images of foreign bodies. And on the top, we see a scan with a very superficial entity that appears to be hyperechoic with posterior shadowing in the right foot. And that's pretty easily seen here. Right up at the top, you've got this shadowing that's coming down, and it's labeled as a foot. So that's how we know where we are. We can see the metatarsal bone down at the bottom of the image, and some tissue edema that surrounds the foreign body as well. In the lower image, we see a brightly reflective object, which is likely a needle shard right here in the middle. And a bit deeper, this one's a bit deeper in the subcutaneous tissue, and there's pronounced reverberation artifact, which I've gone over multiple times, but you can see these parallel lines that generate at the echogenic body and then go down. So this is likely a hollow metal needle tip or fragment that's buried deep and producing those reverberation artifacts. To remove a foreign body using ultrasound guidance, start by adequately anesthetizing the area with local anesthetic. I would also consider, if you've been trained to do them, regional anesthesia with a peripheral nerve block, particularly if the wound is on the foot, which is a common site of injury in an area that's particularly difficult and painful to inject with local anesthetic. Once you've anesthetized the area, center the foreign body on the screen and mark the area with a skin marker as a target point. If needed, make an incision through the skin lateral to the body. You can consider going through the puncture wound if one is present, but if that puncture wound is healed, it's usually better to go laterally and approach from the side because you can see things a little bit better. Once you've done that, you can introduce a sterile hemostat or forceps to grasp the object under ultrasound guidance and remove it. Some people use needles to locate the object and elevate it up to the skin, or use a needle and then dissect with a scalpel to the level of the needle to remove a foreign body. But I generally have good success with making a little incision and then inserting an instrument, and that's the approach that's being seen demonstrated here. Remember that then you should irrigate and ensure hemostasis, and consider if your patient warrants antibiotic therapy as well. Next, let's turn our attention to infections of the skin and soft tissue that have important ultrasound findings. First up, cellulitis. Now, we don't need ultrasound to diagnose cellulitis, right? However, there are a couple of clinical scenarios when I do use the ultrasound machine. One is when there's diffuse skin erythema, but no warmth or swelling or pain, and I'm considering a primary dermatologic condition like an exanthem or dermatitis, or God forbid, even a sunburn. But sometimes I'll pull out the ultrasound to see if there is edema in the subcutaneous tissue, if there is that skin erythema. I also go to the ultrasound if I'm concerned that there could be an abscess that's not clinically evident on my physical exam, or if I think that there could be a deeper or more serious infection such as necrotizing fasciitis. And we'll go over what each of these looks like in turn. But let's start off with plain old simple cellulitis. So here I have three images showing how cellulitis progresses from a normal appearance, as seen on the left, to the classic cobblestone pattern that's often described as being diagnostic, at least in the right clinical setting, of cellulitis. And that's seen on the far right. As the body attempts to fight off invading bacteria, capillaries begin to leak fluid and immune cells into the interstitial space. So in this middle image of early cellulitis, you can see that the subcutaneous tissue has a slightly hyperechoic appearance, but it is starting to appear more fasciculated, and that small pools of anechoic fluid are popping up here and there throughout the subcutaneous tissue. And then on the right, as this patient has progressed a little bit farther with their infection, the pools start to interlink, and the parenchyma of the adipose and connective tissue makes little rivulets or anechoic or hyperechoic fluids that weave between these structural components and thus cause the classic cobblestoning pattern. So we go from essentially no little pools of echogenicity or anechoic, hypoechoic areas to this middle section where we're starting to get these little lacunae. We're starting to see more of a bundled approach. Everything appears a little bit brighter from that initial swelling and edema. And then finally, as that fluid coalesces around these different more confluent structures inside the subcutaneous tissue, you get the classic cobblestone. Now, it's important to remember that cobblestoning, while very sensitive, is not specific for cellulitis. In fact, lots of different conditions, especially those that result in fluid shifts or volume overload, can also create interstitial edema that generates a cobblestone appearance. Oftentimes, patients will have multiple risk factors for infection because of these chronic conditions. So CHF can result in volume overload and then develop venous stasis and stasis dermatitis. And then you get weeping wounds that can serve as entry points for infections. So while ultrasound can help us, especially in otherwise healthy patients, to diagnose cellulitis, it's very dependent on the individual patient and the clinical context in which you're seeing them. One of the biggest quandaries in medicine is how to quickly identify more severe infections such as necrotizing fasciitis, distinguishing the need for surgical interventions and debridement from routine antibiotics for the best patient outcomes. Necrotizing fasciitis is caused by group A strep or anaerobes and a variety of other organisms. And classically, the exam findings are pain out of proportion or subcutaneous emphysema, which raise suspicion for this diagnosis. But those exam findings are finicky and they're not always present. Similarly, ultrasound can help identify subcutaneous emphysema, but the lack of this finding does not itself rule out necrotizing infection. So when in doubt, these patients need close monitoring and surgical consultation regardless of the ultrasound findings that may or may not be present. When gas-producing bacteria are present, subcutaneous emphysema will sometimes be seen on ultrasound as a hazy, diffuse disruption of the normal subcutaneous architecture with posterior shadowing caused by scattering of the sound waves by those air pockets. This appearance looks pretty similar to the appearance of bowel gas as we reviewed in our abdominal lecture, or the lung, as we talked about when looking at the pleural interface in our pulmonary lectures. Sometimes I like to describe this as almost a curtain of haze that obscures the normal architecture. And when you do see these findings, it should expedite surgery for debridement of the necrotic tissue, as very few other etiologies would cause a similar ultrasound appearance. And so on this view, we can see that there's the sort of normal linear layers of the subcutaneous tissue, and then right about here and moving over this way, we start to see what looks almost like lung or like bowel gas, where you have these brightly echogenic irregularities, and then sort of haziness, obscurity. You don't really see anything with detail below that, and that is pretty characteristic of gas. And I've got a dynamic clip as well here. So here's a dynamic image where you can see that as we translate, we lose the normal architecture quite quickly and start to see that hazy curtain-like appearance obscure the structures beneath. Once again, highly suggestive of necrotizing fasciitis. Another quite useful application of point-of-care ultrasound is for the identification of abscesses and risk stratifying patients to determine the best treatment plan when an abscess is present. Abscesses generally appear as round-ish, I say ish, shapes in the skin and soft cutaneous tissue. While sometimes well circumscribed, they can often have a fuzzy appearance at the borders and have multiple pockets or tracts of purulent material throughout the immediate area. They're usually hypoechoic to the surrounding structures, but will often have small, mobile, echogenic debris within their walls, which represents proteinaceous exudate or cell collections, or sometimes small areas of bleeding and clotting. When gentle pressure is applied with the probe, these debris will often swirl around. Kind of looks like a front-loading laundry machine, if you can picture that in your mind's eye. And while there are lots of things that can mimic an abscess on ultrasound, very few will have this swirl sign. So the next slide has an image of what that looks like. So this clip, which isn't the greatest quality, I admit, it does at least demonstrate that with compression, you can see these structures sort of swirling around like a laundry machine. And the fluid inside the abscess being mobile is a great example of the swirl sign that makes an abscess much more likely on your diagnosis. Now, some of the most common mimickers for abscesses on exam and ultrasound include lymph nodes, especially reactive lymph nodes that have swollen up and are painful to the touch. Lymph nodes will classically have a hypoechoic appearance with an inner hyperechoic hilum, which sometimes will show vascular flow if you're using PDI or color Doppler. There should not be a swirl sign or internal echogenic material. And if there is, then you need to think of a suppurative infection such as suppurative lymphadenopathy, which sometimes requires antibiotics, even IV antibiotics, or surgical intervention. Another common mimicker is a simple cyst, especially in the breast or around other endocrine structures. Simple cysts should be well circumscribed, demonstrate anechoic fluid inside the cyst wall with posterior acoustic enhancement, and be non-compressible with ultrasound. Color flow Doppler can actually help rule out internal flow, which sometimes is necessary to make sure the structure is not actually a large vessel being caught in cross-section. So make sure to utilize color flow and image in multiple planes when you see structures that look like this. Ultrasound can also be used to measure the size of these cysts to help direct management, which could range from observation to aspiration and excision, depending on the need. Remember that in our women's health module, there were other examples of breast masses, so go back and review that lesson if you need a refresher. And then lastly, one of the other common mimickers is epidermoid inclusion cysts, which mimic abscesses, especially when inflamed. Some clues that help us differentiate these cysts from true abscesses are that with high-resolution imaging, you can generally see a pore that travels up to the skin, which is the punctum that's seen externally on physical exam. They may or may not have internal debris, but the interior is usually not going to have a swirl sign because the contents of an epidermoid cyst are much thicker and less mobile. So think about how much pressure you have to use when you're expressing these bad boys, and that's not going to swirl around like a nice juicy abscess will. Knowing these mimickers can help you properly diagnose abscesses and direct management towards or away from incision and drainage. Before we move on, let's talk about a little bit of the evidence in the literature that supports the use of point-of-care ultrasound for skin and soft tissue infections. Basically, there's a lot of it. This is just a sample of a few of the quick things that popped up on an image search, a literature search. Let's review some of the highlights. In prospective studies conducted in the emergency room, the use of ultrasound compared to physical exam alone changed management in up to half of cases. So what they found was that without ultrasound, more patients were misdiagnosed as either having an abscess when in reality they just had edema from cellulitis but no discrete pocket of fluids, or they were not offered an IND due to clinicians missing subtle abscesses on their physical exam. While saying that up to half of all patients could be better served by ultrasound investigation is a bit of a stretch for me personally, it does reinforce that sometimes our physical exam isn't as sensitive as direct tissue visualization, and the use of ultrasound to do this has a low cost, a low harm modality, and a low risk for our patients. Patients that receive ultrasound studies at the bedside had a decreased length of stay in the emergency room, and when performing incision and drainage of abscesses using ultrasound guidance, there is a lower risk of complications such as requiring multiple sticks or cuts, treatment failure, postoperative wound complications, and hemorrhage. Another interesting study found that abscesses which are small, which they define as those being less than 1 centimeter in diameter, treatment with antibiotics alone was non-inferior to incision and drainage, which could be helpful in considering and counseling patients that might have a technically challenging IND based on the location, or if they're a squirming toddler, for example, that you may not want to subject to an invasive procedure if they could be adequately managed with antibiotics alone. Some of these patients may be good candidates for a trial of oral antibiotics if they have a good understanding, you've counseled them well, they have adequate follow-up, and they consent to the risk of delaying treatment if the antibiotics are insufficient. Lastly, for breast abscesses that are small, POCUS-guided aspiration is considered a better treatment than surgical IND, which usually has to happen into the OR due to the significant pain associated with these lesions. So we can potentially save a patient from the risks and costs of general or regional anesthesia and a hospitalization if we can successfully treat these with minimally invasive procedures. Next, let's move on to some lumps and bumps that are commonly seen and what their ultrasonographic findings entail. We already discussed sebaceous cysts or epidermoid inclusion cysts, but as a reminder, these are usually well-demarcated, round or oblong hypoechoic structures that can often be seen to have a pore that leads up to the epidermis. Ganglion cysts are caused by synovial fluid collecting outside of a joint space, and as expected, we can sometimes see this fluid tracking into the joint space, which is a clear indication of a ganglion cyst. However, depending on the anatomy and size, you may not always see this communication. But that being said, you should always suspect a ganglion cyst when the lesion in question is located near a joint, particularly if the internal appearance is hypoechoic and well demarcated from surrounding tissues. Lipomas are well demarcated superficial structures that usually appear isoechoic to the surrounding tissue because they're made up of fat and connective tissue that arises from normal subQ. These are typically benign masses that are mobile, have minimal ultrasound artifact, and lack significant Doppler flow. I most commonly use POCUS not to diagnose lipomas, but instead to measure them when I'm planning for excision, to define my margins and to pre-screen for less common but scarier conditions such as deep lipomas, lipomas that have fixture to fascial or other structures, or abnormal vasculature that could be suggestive of a liposarcoma or else require a more extensive surgery and diagnostics. Arteriovenous malformations are less common than these other findings, but they do have an extremely unique appearance on ultrasound as anechoic bundles that will show bidirectional chaotic flow on color Doppler. The best way to practice looking at these images is by finding a patient on ESRD with hemodialysis that has a fistula that's functional, and they have basically a surgically created AVM that appears really similar. And so if you want to see kind of what this could look like, looking at a patient on dialysis with a fistula is a good way to practice that. Once again, less common, but pretty unique finding on ultrasound. Pilomatrixomas are uncommon lesions, but they do have a unique appearance that often prompts parents to seek medical attention for kiddos that are affected by them. They most commonly present as a small, firm lesion on children, usually on the head or neck, but they can be other places as well, and are derived from abnormal proliferation of the hair follicle cells at the dermal subcutaneous junction. On ultrasound, they are ovoid in shape with a heterogeneous texture that will often show hyperechoic or calcific appearance with posterior shadowing. And their location at the dermal and subcutaneous junction is a hint at their origin. They will often show dermal thinning over the superior aspect of the lesion, and these often need to be referred to dermatology for excision and investigation, as there is a low rate of malignant transformation. Another common referral, while not technically a skin or soft cutaneous tissue, issue is for lumps in the groin or the umbilical area, which could be mistaken for lipomas or other lesions. While lipomas and lymph nodes, abscesses, and cysts are common in the inguinal region, don't forget that it could be an inguinal hernia as well. We talked about this in our abdominal module, but as a reminder, intestinal hernias usually travel in the potential spaces of the inguinal or femoral canals or through defects in the abdominal wall, and often show peristalsis and bowel gas on dynamic imaging. They can start to develop hyperemia or adjacent edema if they become incarcerated or strangulated. And so here, just as a reminder, we've got this nice lesion right here in the center of the screen, and if you watch dynamically, it appears that there's things kind of sliding and moving through it, and that's an example of peristalsis in a hernia. Now there's many more findings, both benign and otherwise. So before we talk about malignancy, just a reminder that we've really only touched the tip of the iceberg here when it comes to skin and soft tissue findings. Especially as ultrasound technology progresses, more and more uses of point-of-care ultrasound will likely be developed to investigate these organs, which are immediately visible due to their superficial positions in the body. So I've covered some of the common things and a few of the more rare things, but there's still a ton out there. And I would encourage you to, if you're planning to use this in your future practice, to review the literature and to stay up to date with some of the really cool findings and studies that are coming out now about ways we can use ultrasound to diagnose these problems. Lastly, let's close out this lesson with a brief examination of some red flag findings that should raise your suspicion for skin and soft tissue malignancies. While being some of the most common types of cancer encountered by generalists, skin and soft cutaneous malignancies have an extremely variable appearance using ultrasound. New developments are being utilized with some high-tech machines and research centers to use AI protocols that help identify cancers with ultrasound. But the gold standard, at least for the foreseeable future, is to continue to examine these lesions histologically via biopsy or excision. As the old adage says, when in doubt, cut it out. And unfortunately for us, POCUS is not a reliable tool for avoiding excision or biopsy at this time. That being said, every now and then, during the investigation of a lump or lesion, you may run across the following findings that should raise your suspicion for a malignant process. Some of these findings include a large size, typically defined as being greater than about 4 centimeters in diameter, a location that's deeper in the body, especially if underneath an investing fascial plane, sudden or rapid onset or growth, a firm consistency on palpation and echo texture, with mixed echogenicity and or unusual blood flow and vascularization. Additionally, obvious connection or adherence to the surrounding structures on ultrasound should raise suspicion for a malignant process. And here I've just chosen a couple of different things, some of which are easy to pick out. Like you might say, hey, this middle one here's got some abnormal flow to it. It's got some echogenic components. It's got some hypoechoic or anechoic components. It's a solid structure. It's firm to the touch and palpation, non-compressible. And so those things would likely raise your suspicions. But looking at this, like it'd be pretty easy for me to say, hey, this might just be a little mucoid ganglion cyst or mucoid cyst over this joint. But in reality, it's a structure that's adherent to the deeper bony structures. And so these are subtle, and you just got to have a high index of suspicion so that you don't miss any of these cases. Not a very satisfying answer, but it is the one that we're operating on right now. So in this lesson, we acquainted ourselves with some of the normal skin and soft tissue findings, as well as spending a good amount of time discussing foreign bodies, infections of the skin and subcutaneous tissues, and talking about what the literature says about using POCUS for the management of each of these findings. We also reviewed some of the common benign findings that may present as lumps or bumps in your clinic or in the ER, and touched on some of the findings that ultrasound or physical exam that should make you more suspicious of a potentially cancerous or threatening lesion. So now that we've discussed the skin and subQ, let's dive a bit deeper into the muscles, tendons, and joints, and the ways ultrasound can help us diagnose musculoskeletal injuries in our next lesson.